Now we are going to discuss stomach. First of all, we are going to discuss the anatomy and physiology in stomach. Now see the normal anatomy. This is stomach. This is incisura angularis. So what are the normal parts of stomach? You can see this is cardia. This is angle of His. Angle of His. This is fundus. This is body. This is antrum. This is pylorus. And this is incisura angularis. Incisura angularis. So these are the parts of stomach. After that, lots of questions are asked about that what is the most common site of this particular condition. So first, cardia. Cardia is the most common site of Mallory-Weiss syndrome. Cardia is the most common site of Mallory-Weiss syndrome. After that, fundus. Fundus is the most common site of stress gastritis or stress ulcers. Stress gastritis or stress ulcer. Second, fundus is the most common site of carcinoma stomach in pernicious anemia. Carcinoma stomach in pernicious anemia. After that, body. Body here is the location of, this is the most common site of pacemaker cells of stomach or gastric pacemaker cells, and the name is interstitial cells of Kejal. So it's the most common site of gastric pacemaker cell. Gastric pacemaker cell, and that is interstitial cells of Kejal. Interstitial cells of Kejal. After that, antrum. This is the most common site of carcinoma stomach. Overall, this is the most common site of carcinoma stomach. And after that, incisura angularis. This incisura angularis is the most common site of gastric ulcer. So this is most common site of gastric ulcer. These are the questions related to anatomy. Now you know that there are two nerves in relation to stomach, and those are vagus. One is right vagus, one is left vagus. Left vagus is anterior, right vagus is posterior. Now see the relation of vagus with stomach. So this is the stomach. This red colored is this left vagus, and this left vagus is anterior, and this green colored is the right vagus, and you can see this is the posterior. First branch of right vagus is CNG. What's the full form? It's known as criminal nerve of Gracie. The full form is criminal nerve of Gracie. What is the first branch of left vagus? It's the hepatic branch. This is hepatic branch. After that, what is the second branch of this right vagus? This is known as celiac branch. This is celiac branch. After that, there are seromuscular branches. Now see, these are seromuscular branches of vagus. So you can see the seromuscular branches of vagus. Now the terminal branch of vagus, which is supplying the pylorus, it's known as nerve of Latarjet. So this is nerve of Latarjet. Now here you can see there are two nerve of lateral jet. Anterior nerve of lateral jet is the branch of left vagus. Posterior nerve of lateral jet is the branch of right vagus. After that, this nerve of lateral jet is having terminal nerve endings, and these endings are something like this. Now can you see? So the appearance is something like this, and this is known as crow's foot. So the terminal nerve endings are known as crow's foot. Why I'm telling you this? Because I want to explain vagotomy. Vagotomy is very important. So there are three types of vagotomy: highly selective, selective, and truncal vagotomy. You can see here in highly selective vagotomy, I'm going to divide these seromuscular branches. So this is highly selective vagotomy. If I'm dividing vagus just below hepatic and celiac branch here, this becomes the selective vagotomy. And if I'm going to divide the main trunk of vagus, this becomes truncal vagotomy. So these are the types of vagotomy. After that, lots of questions are asked about vagotomy. See, I'm repeating. So this highly selective vagotomy, here there is division of seromuscular branches. Selective vagotomy is the division after celiac and hepatic branch. After celiac and hepatic branch. And truncal vagotomy is the division of main trunk. Division of main trunk of vagus. So these are the questions. After that, which one is preferred in which condition? See, this highly selective vagotomy. Obviously, this one is having lowest or minimum morbidity, and this one is associated with maximum recurrence rate. So here there is minimum morbidity and there is maximum recurrence rate. What do you mean by maximum recurrence rate? There is a simple concept. See, generally in most of the patients of peptic ulcer, there is increased acid output. In majority of cases, there is increased acid output. Second, the acid production is under the control of vagus. So if we are going to perform the vagotomy, it is going to decrease the acid production or output, and after that what will happen? There is faster healing of peptic ulcer. So when I perform highly selective vagotomy, what happens? There is maximum recurrence rate because I'm just dividing the seromuscular branches. But just opposite occurs in cases of truncal vagotomy. So what happens? In truncal vagotomy, there is maximum morbidity, but there is minimum recurrence rate. There is maximum morbidity but minimum recurrence rate. So these are the questions related to anatomy. Now in detail we are going to discuss very important topic, and that is peptic ulcer. Peptic ulcer. Peptic ulcer, it's of two types: duodenal ulcer and gastric ulcer. Which one is more common? First question. The most common site of peptic ulcer is duodenal ulcer. Now you must be knowing that H. pylori is responsible for peptic ulcer. What percentage of duodenal ulcer? 90%. And what percentage of gastric ulcer? 75%. So H. pylori is responsible for 90% of duodenal ulcer, 75% of gastric ulcer. Second question. What is the most common type of peptic ulcer? So most common type of peptic ulcer, it's the duodenal ulcer. So obviously, what's the most common? Question is asked, what is the most common type of peptic ulcer? So most common type of peptic ulcer is the duodenal ulcer. Second question, what is the most common site Most common site of peptic ulcer. The most common site of peptic ulcer, it is the first part of duodenum. So it's the first part of duodenum. After that, there is a basic difference between peptic ulcer and duodenal ulcer. What? That generally in duodenal ulcer. After that, there is a basic difference between duodenal ulcer and gastric ulcer. What? That generally in duodenal ulcer, location is fixed. It's the first part of duodenum. That's why in duodenal ulcers, the treatment depends on the complication. And in gastric ulcer, the location is variable. And since the location is variable, that's why treatment depends on the location. So very important statement. Generally, in duodenal ulcer, treatment depends on complications. Treatment depends on complications, and in gastric ulcer, treatment depends on location or type of gastric ulcer. So first you should know that what are the types of gastric ulcer. There is a classification system for gastric ulcer known as modified Johnson's classification. Modified Johnson's classification. Now see what are the types. This is the stomach. This is incisura angularis. Now see, in type 1, the ulcer is located at incisura angularis. In type 2, there are two ulcers, one in the body, one in first part of duodenum. In type 3, there is pre-pyloric ulcer, just before pylorus. In type 4, it's high on lesser curvature, and in type 5, it is NSAIDs induced anywhere. So you can see, this is type 1, this is type 2, this is type 3, this is type 4, and this is type 5. So these are 5 types of gastric ulcer. Have a look. Type 1. Type 1. It's located at incisura angularis. Located at incisura angularis. Now see, type 2. Type 2, there are two ulcers. There are two ulcers. First, one in body of stomach, one in body, and one at first part of duodenum. First part of duodenum. So one at first part of duodenum. After that, type 3. Type 3 is pre-pyloric. This is pre-pyloric ulcer. Type 4. It's high on lesser curvature. It's high on lesser curvature. It's high on lesser curvature. And type 5 is the NSAIDs induced ulcer. NSAIDs induced ulcer. Clear? Question is asked that first question, what is the most common type of gastric ulcer? So first question, the most common type of gastric ulcer, yes, it's the type 1. After that, second question, most of these gastric ulcers are associated with blood group O. But be careful, type 1, this is associated with blood group A. So most type of gastric ulcers are associated with blood group O, but type 1 is associated with blood group A. After that, second question, out of these 5 types, you can see type 1, type 4 and type 5. These are associated with either normal or low acid production. Normal or low acid production, whereas type 2 type 2 and type 3. These are associated with high acid production. High acid production. Simple question. Now, I told you that to decrease acid production or output, what we have to perform? Vagotomy. It means we will never perform vagotomy in which type of gastric ulcers? Type 1, type 4 and type 5. And we have to perform routinely the vagotomy in which types of ulcers? Type 2 and type 3. Now see the management of gastric ulcer. Management of gastric ulcer. So first, type 1. In type 1, we go for distal gastrectomy. In type 1, we go for distal gastrectomy. After that, in type 2 and type 3, the treatment is same. And what we go for? Truncal vagotomy. We go for truncal vagotomy plus antrectomy. So for type 2 and 3, we go for truncal vagotomy plus antrectomy. After that, for type 4, you have seen that in type 4, ulcer is located high on lesser curvature, and that's why we have to go for certain specialized procedures. So here, named surgeries are performed, and those are first, Sandis, second, Pouchet, Sandis, Pouchet, third, Kelling-Madlener, Kelling-Madlener, and fourth, Shoemaker. Kelling-Madlener and Shoemaker. So these are the named surgeries performed. And for type 5, what is the treatment? We have to stop NSAIDs. We have to stop NSAIDs. So this is how we are going to manage the gastric ulcer. Now I'm going to discuss the duodenal ulcer. And in the beginning, I told you the management of duodenal ulcers depends on the complications. So first, you should know what are the complications of peptic ulcer. Complications of peptic ulcer. First is intractability. Intractability means the ulcer is not healing after medical management. So ulcer is not healing after medical management. So question is asked, what is the preferred treatment for intractable duodenal ulcer or chronic duodenal ulcer? And generally what we go for? Highly selective vagotomy. So here we perform highly selective vagotomy. It's performed for intractable duodenal ulcer or chronic duodenal ulcer. Second is bleeding. Third is perforation. And fourth is the gastric outlet obstruction. Gastric outlet obstruction. First question is asked, what is the most common complication of peptic ulcer? So it's the bleeding. Bleeding is most common complication of peptic ulcer. Second question, what is the most common complication of gastric ulcer? It's the perforation. So perforation is the most common complication of gastric ulcer. Now how to remember? Mnemonic is simple. It's the BP and this is PG. So the mnemonic is BP, PG. BP means bleeding in peptic ulcer. PG means perforation in gastric ulcer. So these are the complications. I discussed the treatment of intractable duodenal ulcer. Now coming to bleeding and perforation in duodenal ulcer. If you see this simple diagram, this is the stomach and this is the first part of duodenum. Now see the relation of this vessel. This is the gastroduodenal artery. And this gastroduodenal artery passes just behind the first part of duodenum. Now see, in duodenum, ulcer is either located at anterior wall or ulcer is either located at posterior wall. It is said that anteriorly located ulcers perforate and posteriorly located ulcers bleed. Question: if posteriorly located ulcers bleed, most commonly involved artery in bleeding duodenal ulcer is the gastroduodenal artery. So two statements. First, anteriorly located ulcers perforate and posteriorly located ulcers bleed. Posteriorly located ulcers bleed. After that, question is asked, what is the most commonly involved artery in the bleeding duodenal ulcer or in the bleeding peptic ulcer? So question: most commonly involved artery in bleeding duodenal ulcer, and that is gastroduodenal artery. Now how we are going to manage the bleeding? First, see, in bleeding, what we have to go for? Initially, we have to go for endoscopy, but if it's not controlled, what we have to go for? Surgical treatment. Now see what? We have to open the duodenum. This is the stomach. This is the gastroduodenal artery. So what? I'm going to open the duodenum. So I perform a duodenotomy. After duodenotomy, I'm going to ligate the bleeding vessel. After that, I have to perform the truncal vagotomy to decrease acid output. And after that, at this point of time, after this, we have to perform what? Pyloroplasty. So at this site, we have to perform pyloroplasty. So the final diagram would be something like this. When I perform the pyloroplasty, it's something like this. So we perform longitudinal incision, but we close it transversely. So this is pyloroplasty. It prevents the stricture formation. So I'm repeating. What's the treatment of bleeding? Treatment of bleeding duodenal ulcer? We perform duodenotomy. Duodenotomy plus ligation of bleeding vessel, ligation of bleeding vessel plus truncal vagotomy plus pyloroplasty. And this question was asked 2 to 3 times in all India. So this is the treatment of bleeding duodenal ulcer. In cases of perforated duodenal ulcer, what we are going to do? See, here is the duodenal ulcer perforation. So what we do? We put a patch of omentum and which is having vascularized pedicle, and after that we are going to suture it. So we are going to suture it, and this is known as omental patch repair, also known as modified Graham's repair. Modified Graham's repair. Be careful, when Graham's performed this repair, he just put a piece of omentum over the perforation and he sutured it. But in modified Graham's repair, we are using vascularized pedicle of omentum. So this is also known as omental patch repair. Omental patch repair. So here you can see that we are taking a mobilized pedicle of greater omentum and we are putting this mobilized pedicle here, and after that what? We are going to perform the suturing. So here we are going to perform the suturing. So this is omental patch repair, also known as modified Graham's repair. Next complication is the gastric outlet obstruction. gastric outlet obstruction. So see, there are two questions asked about gastric outlet obstruction. First, gastric outlet obstruction because of peptic ulcer is rare. Gastric outlet obstruction because of peptic ulcer is rare. So next question, most common cause of gastric outlet obstruction. Be careful, it's the carcinoma stomach. It's the carcinoma stomach. Next question, most common site of obstruction in gastric outlet obstruction. Now this is very easy question. What is the most common site of peptic ulcer? It's the first part of duodenum, and that is the site of gastric outlet obstruction. So it's the first part of duodenum. First part of duodenum. Now see what is the problem in gastric outlet obstruction caused by duodenal ulcer. This is the stomach, and in majority of cases there is ulcer at the first part of duodenum, and because of this ulcer what happens, there is edema around the ulceration. And if there is edema around the ulceration, because of this what happens, there is gastric outlet obstruction. So how we are first going to diagnose it? So gastric outlet obstruction is diagnosed by saline load test. Saline load test, how we do it? First we have to empty the stomach. So first step, empty the stomach with nasogastric tube. So we insert the nasogastric tube and we perform the aspiration. After that we have to instill the saline. How much? 750 ml of saline. Instill 750 ml of saline. After that ask the patient to sit. So patient is placed in sitting position. Patient is in sitting position. And after that we have to perform the nasogastric aspiration after 30 minutes. So perform nasogastric aspiration after 30 minutes. Normally on nasogastric aspiration, how much is the residual saline? It's less than 400 ml. So if the residual saline is less than 400 ml, it's normal. But if it's more than 400 ml, the residual saline, if it's more than 400 ml, it is suggestive of gastric outlet obstruction. Now whenever we suspect gastric outlet obstruction, what we have to perform? First, management. Patient should be nil per oral by mouth for 48 hours. And what we have to give? We have to give IV fluids. Question is asked, what is the fluid of choice? It's the normal saline. The fluid of choice, it's the normal saline. Now see what's the good thing? The good thing is that in majority of cases there is inflammatory edema around the ulceration. So if you are not going to allow anything orally, the edema is going to settle, and if edema settles, most of the patients improve. So what's the good thing? Most patients improve after conservative management. Most patients improve after conservative management. And for non-responding patients, what we have to perform? We have to go for surgery. For non-responding patients, what we have to go for? Surgery. And with surgery, generally the treatment of choice is truncal vagotomy plus antrectomy. This question is asked. This is the treatment of choice in gastric outlet obstruction. Now see how we are going to perform this. You can see this is stomach and this is the duodenum. Here is the ulceration, and because of that here is the fibrosis and stricture. So what I'm going to perform, antrectomy, and simultaneously I'm going to perform the truncal vagotomy. But in certain cases, see the problem at this point here. Here there is extensive fibrosis or scarring, and because of extensive fibrosis or scarring, the antrectomy becomes difficult. And if antrectomy becomes difficult, in those cases we perform truncal vagotomy plus gastrojejunostomy. So what is the alternative treatment? You can see here, in certain patients we can go for this kind of treatment if antrectomy is difficult. So if it's not possible, due to extensive fibrosis or scarring, in that case we perform truncal vagotomy plus gastrojejunostomy. So be careful in exam. Two questions are asked. First, what's the treatment of choice in gastric outlet obstruction caused by peptic ulcer? Is the truncal vagotomy plus antrectomy? And if antrectomy is not possible because of excessive fibrosis or scarring, in that case the treatment of choice is truncal vagotomy plus gastrojejunostomy. So these are the complications, and you saw how we managed the complications caused by duodenal ulcer. Now we are going to discuss the gastrectomy. So question is asked, who performed first gastrectomy? So first gastrectomy, it was done by Billroth. It was done by Billroth in 1881. After that there are two types of gastrectomy, based on the method of reconstruction and based on the method of amount of stomach removed. So see the types of gastrectomy. Types of gastrectomy. First, based on the method of reconstruction. Based on method of reconstruction. So it's the Billroth 1 gastrectomy, Billroth 2 gastrectomy, and it's the Roux and Y gastrectomy. So see, first is Billroth 1, it's Billroth 2, and it's the Roux and Y. Now see how it's done. First of all, we are going to discuss the Billroth 1 and 2. So you can see here, this is the stomach and this is the duodenum. In this case, you can see I'm going to remove this part of stomach. If this part of stomach is removed, can you see I'm left with only this much part of stomach, and I'm left with duodenum. If I'm going to suture duodenum to gastric remnant, this is known as Billroth 1. It's Billroth 1. And what should be the other name? You can see stomach is anastomos to duodenum, so the name should be gastroduodenostomy. So its name should be gastroduodenostomy. Now see what's Billroth 2. Here you can see that this is the gastric remnant and this is the jejunum, and I'm going to suture this jejunum to the gastric remnant. Clear? So this is Billroth 2. This is Billroth 2. And what should be the other name of Billroth 2? Obviously, it's the gastrojejunostomy. And here you can see what kind of gastrojejunostomy. Since a loop of jejunum is sutured to stomach, it's the loop gastrojejunostomy. So other name, It's the loop GJ or loop gastrojejunostomy. What is the third method? Third method, you can see this is the gastric remnant and this is the jejunum, this is the duodenum, this is the jejunum, and here you can see this is the Roux-en-Y anastomosis. So here this is this is after gastrectomy, Roux-en-Y gastrojejunostomy. So this is Roux-en-Y gastrojejunostomy. So these are three methods based on the type of reconstruction. Now see the methods based on the amount of stomach removed. Type of gastrectomy based on amount of stomach removed. Amount of stomach removed. Simple. Now first one is total gastrectomy. So obviously in the total gastrectomy we are going to remove the whole stomach. After that there is near total gastrectomy, and in the near total gastrectomy more than 90% of stomach is removed. After that there is subtotal gastrectomy. In subtotal gastrectomy we remove 80 to 90% of stomach. After that there is partial gastrectomy. There is partial gastrectomy, and in partial gastrectomy we remove 65 to 75%. After that there is hemigastrectomy, and as the name is self-explanatory, hemi means 50% of stomach is removed, and after that there is antrectomy. Antrectomy is also known as distal gastrectomy. So it's the antrectomy. Antrectomy is also known as distal gastrectomy. Both are same. And in antrectomy or distal gastrectomy, we remove generally 35 to 50%. 35 to 50% of stomach. Now see some of the commonly performed gastrectomies. So here you can see some of the commonly performed gastrectomy. First is the total gastrectomy, in which whole stomach is removed. And here you can see subtotal gastrectomy. Here we are going to remove 80 to 90% of stomach. And distal gastrectomy, also known as antrectomy, and here we are going to remove 35 to 50%. So these are the types of gastrectomy based on the amount of stomach removed. So questions are asked, what are the complications of gastrectomy? See the complications of gastrectomy. First, the complications of gastrectomy secondary to gastric resection. Secondary to gastric resection. So first is dumping syndrome. Is the dumping syndrome, and the second is metabolic disturbances or metabolic complications. Metabolic disturbances. Second, secondary to gastric reconstruction. Secondary to gastric reconstruction. And these are first afferent loop syndrome. Afferent loop syndrome. Second, efferent loop obstruction. Efferent loop obstruction. Third is alkaline reflux gastritis. Alkaline reflux gastritis. And fourth is retained antrum syndrome. Is the retained antrum syndrome. So these are the complications based on secondary to gastric reconstruction. Third set of complication. These are post-vagotomy syndromes because of vagotomy. So post-vagotomy syndromes in which there is post-vagotomy diarrhea, post-vagotomy diarrhea. There is post-vagotomy gastric atony, and incomplete vagal transaction. This leads to recurrence. Incomplete vagal transaction. So these are the complications. After that, one simple question is asked, what is the function of stomach? And you must be knowing that the function of stomach is temporary storage of food and mixing of food with fluid. So what stomach is going to do? It converts hyperglycemic and hyperosmotic content into isoosmotic, so that in small amount the food is going into duodenum in the form of chyme and it is digested and absorbed. Now see the problem. If a patient is having this kind of gastrectomy, and you know what kind of gastrectomy is this? Is the Billroth 2, and patient is going to eat something or drink something, what will happen? That food or fluid will immediately enter into the proximal part of jejunum, and because of that there will be constellation of symptoms, and this is known as what? Dumping syndrome. It's very important, frequently asked in exam. So have a look and you can see this dumping syndrome is more common with Billroth 2 as compared to Billroth 1. So what's the dumping syndrome? It's the constellation of symptoms or group of symptoms. So constellation of symptoms caused by accelerated, it's caused by accelerated emptying or dumping of hyperosmolar content, hyperosmolar content into hyperosmolar content into proximal part of jejunum or proximal part of small intestine. And you know it is more common with Billroth 2. It is more common with Billroth 2 as compared to Billroth 1. This dumping syndrome is further divided into two types, early dumping and late dumping. What happens in early dumping? See, somebody is having lunch or dinner with you at the dinner table, and during lunch or dinner, patients generally collapse within 15 to 30 minutes. So the symptoms which are occurring within 15 to 30 minutes, it's early dumping. Now see what's the cause. When the person is going to eat or drink something which is hyperosmotic, that is going to enter into jejunum, and because of that there is secretions from the jejunum. How much? 2 to 3 liters. So 2 to 3 liters secretions from jejunum is going to enter into jejunum lumen, and because of that this person goes into third space loss, and because of that there is hypovolemia and patient collapses. Now see what happens in late dumping. In late dumping there is hyperglycemic content into jejunum. Because of that after 2 to 3 hours there is reflex increased release of insulin, and because of this there is reactive hypoglycemia. So patient will be having signs and symptoms of reactive hypoglycemia in late dumping. So see, it is of two types. First is the early dumping, and second is the late dumping. Early dumping, it is seen within 15 to 30 minutes of meals. It's within 15 to 30 minutes of meals. Now what's the cause here? Here there is hyper osmolar content in jejunum or in small intestine. Because of that, there is increased secretion into jejunum. Because of that, there is third space loss. And because of this third space loss, what will happen? There is hypovolemia. So one simple principle is there. If any patient who is having hypovolemia, how we are going to manage? Generally, this patient collapses. So we lie the patient supine, and the management is what? IV fluids. So the management of this condition is what? IV fluids. Now late dumping. This late dumping is seen after 2 to 3 hours of meals. It's after 2 to 3 hours of meals. And what is the problem here? Here there is hyperglycemic content. There is hyperglycemic content in the jejunum. Because of that, increased insulin release. And because of increased insulin release, there is reactive hypoglycemia. Is the reactive hypoglycemia. So this question was asked many times, that what is the cause of late dumping? Is the reactive hypoglycemia. Now how we are going to manage any patient of hypoglycemia? Obviously we give what? Oral glucose. We give oral glucose. Now see, this is the emergency management. But what is easier? Prevention of dumping is easier than its treatment. So how to prevent dumping syndrome? Prevention of dumping syndrome. The first thing, we advise the patient about dietary modification. We ask the patient that take small frequent meals. The food stuff which is responsible for your problem, decrease the content. And what's that? It's the carbohydrate. So low carbohydrate, high fat, high protein diet. Second, you should not take high calorie drinks. So first is dietary modification. So we advise the patient for small frequent meals. First thing, small frequent meals. After that, low carbohydrate, high fat and high protein diet. So low carbohydrate, high fat, high protein diet. Third, avoid high calorie drinks. Avoid high calorie drinks. After that, avoid liquids during meals. Avoid liquids during meals. Most of the patients are going to improve after dietary modification. If patient is not improving, what we can do? We can switch off the secretions. And I told you what is the universal switch off. The universal switch off is somatostatin. And the better analog of somatostatin, that is octreotide, it will decrease the secretions in the jejunum and it will decrease the insulin secretion. So second is octreotide intake. So we advise the patient for octreotide intake. Now what's the advantage here? It decreases insulin secretion and it decreases the intestinal secretions. Clear? So most of the patients are going to improve. Only little fraction of patients who are not going to improve even after octreotide intake, in those cases we go for surgery. And what are the options available? We can convert convert Billroth 2 into Billroth 1. Convert Billroth 2 into Billroth 1. Or we can go for interposition of anti-peristaltic segment, anti-peristaltic segment of jejunum. Now what is the meaning of this statement? See, suppose in this patient, this is the Billroth 2 gastrectomy. And after this Billroth 2 gastrectomy, this patient is having dumping syndrome. What you do? You just cut this part of jejunum. After cutting this part of jejunum, can you see what is the direction of peristalsis? It's like this. So you cut this part of jejunum and this is the direction of peristalsis. Now what you do? You reverse this part of jejunum. So when you reverse it, what happens? On reversal, the direction of peristalsis is towards up. So here what happens? We remove this part of jejunum. After that, we are going to put this part of jejunum which is reversed. So it is the anti-peristaltic segment. So here can you see, I'm going to interpose this anti-peristaltic segment where the direction of peristalsis is in opposite direction. So this is also going to help. So this is interposition of anti-peristaltic segment of jejunum. So these are the options which are done to prevent the dumping syndrome. Now we are going to discuss the metabolic complications of gastrectomy. What are the metabolic complications? So metabolic complications of gastrectomy. Question is asked, what is the most common metabolic complication of gastrectomy? And this is iron deficiency anemia. So the most common metabolic complication, is the iron deficiency anemia. Now why there is iron deficiency anemia after gastrectomy? See, generally whatever the iron we take, it is in Fe3 plus form, and after that it is converted into Fe2 plus form because of acid. So this is Fe3 plus form converted into Fe2 plus form because of acid, and this is oral form of iron, and this is the absorbable form. Is the absorbable form, and this is the oral form. What is the problem? Whenever there is decreased acid production because of gastrectomy, there is lesser conversion of Fe3 plus into Fe2 plus, and because of that there is lesser absorption. So how to manage this iron deficiency anemia? Here we go for management is increased oral supplementation. So it's managed by increased oral supplementation. Second is when more than 50% of stomach is removed. In that case, patient develops megaloblastic anemia. The second is megaloblastic anemia. When more than 50% of stomach are removed. In that case, there is megaloblastic anemia. Now, what is the problem? Basically, there is absorption of B12, and in this absorption, intrinsic factor plays important role, and this intrinsic factor is secreted from parietal cells, and the maximum concentration or major concentration of this parietal cell is in the proximal part of stomach. So when more than 50% of stomach is removed, there is deficiency of intrinsic factor, and because of that, there is decreased absorption or no absorption of B12. So how to manage this megaloblastic anemia since there is no intrinsic factor? So here we go for lifelong, we go for lifelong parenteral supplementation. Lifelong parenteral supplementation.